I'm Timmy Davis. I am the Policy Director at the Psilocybin Access Rights campaign, and I'm also the Director of Psychedelic Policy and Regulation at the Centre for Evidence-Based Drug Policy. The Centre for Evidence-Based Drug Policy is a think tank that sits between civil society and Parliament. We have a Labour MP as a chair, and essentially what we try and do is take the fantastic work that's done by researchers throughout the space, the drug policy space in general that is, and universities across the world, and crunch it in such a way so that they don't just end up sort of getting dusty on a shelf, actually make a political impact. So you might see me, for example, going into a meeting with a minister in the Home Office with one big stack of evidence and one pager. I give this big stack of evidence to all the minister's staffers and his officers, and then I give him this one pager with the ask right at the top, because simply politicians don't read the fantastic academic work that's out there, and they don't even read the policy reports, and often nor do their staffers. So we exist to try and give the policy work that kind of political punch, put it in the right places at the right times to make a difference. We don't just work on the psychedelics, but my particular focus is on the psychedelics. For the past 5 or so years, I've been running the psilocybin rescheduling project, which has gone pretty well. We've been relatively successful. The Advisory Council on the Misuse of Drugs have extended a research report that they were doing into barriers to researching synthetic cannabinoid receptor agonists, and started to look at controlled drugs, barriers to researching controlled drugs more generally. They've put out that report with their recommendations, and now we're waiting on the Home Office to accept them. It's taking a long time. It's incredibly frustrating. In fact, the first calls for lifting those barriers to research were back in 2017. So we're still pushing on that every single day. It looks like barriers to research are going to be lifted, not only with psilocybin, but with psychedelic drugs and other controlled drugs throughout Schedule 1. But we think that it's important to acknowledge that while barriers to research being lifted is, incredible, there's still a massive 50-year historic injustice of psilocybin and the other psychedelics being placed in Schedule 1 without any reference to an evidence base. Plus, there's also the question of patient access. So even if we were to get psilocybin rescheduled, what we would find ourselves with is the possibility for prescribers to be able to give patient access, but no infrastructure. No ethics board, no regulation, and this is the problem that I've been looking at with this increased access to medical psychedelics campaign. I'm going to tell you a little bit about it. So essentially what we're interested in is this point here, this point where the psychedelic substance, let's take psilocybin as our example, has passed through stage 1, 2, 3 clinical trials, and has ended up in stage 4. It's received a market authorization, it's able to be prescribed. We're thinking about what's going to happen here. And there are a number of interesting points that we'll get to throughout this that are relevant to the product license application. So about the active ingredients, the type of patients, and the dosing. But first of all, let's think about routes of access. So, of course, illegitimate use is a term that we're using defined through the current structures of regulation and legislation in the UK. Lots of other people, lots of other cultures might think that their kind of use is completely legitimate, perhaps even more legitimate than the use of psychedelic drugs on clinical trials. With their very strict, controlled settings that are necessary for the collection of data to justify these drugs being put on the market in these Western countries. So the other routes of access currently are completely unavailable in the UK. The only legitimate route of access is through a clinical trial when a research group has a Schedule 1 license. Anybody who wants access at the moment has to take these massive risks. They have to go illegitimate, they have to go to the underground or go abroad. So what we're wanting to do with this campaign is essentially make a route of access available that means that people can go get it easily and accessibly, perhaps affordably, without having to take those kinds of risks. We think that if you open up these safe pathways, then people won't go that other way and take the unnecessary risks. So, of course, we want to see reducing illegitimate use, increased private clinical use, and ultimately increased NHS access, because that's where we get the most equitable access on the public healthcare system. So you've got these questions of what will affect access. As I said, when you've got this product market authorization application, you have the product labeling. So this is down to the drug developers. You know, they write which clinical population it's for, what's the recommended dose, there's risk management profiles, there's lots of things that sort of restrict how these drugs could be rolled out and used. We don't have much control over that. We can talk to the drug developers, but ultimately we can't really affect what decision is made between them and the MHRA. Then there's the scheduling. So a drug being in Schedule 1 means that it can be prescribed, it can only be prescribed on a clinical trial. Whereas if it reaches market authorization, it triggers a automatic review of the scheduling with the assumption that it would move to Schedule 2. Schedule 2 means that it can be prescribed by doctors, but there are still relatively tight controls and restrictions around, say, record keeping, storage, transport, these kind of things. If it was in a schedule below that, say 3 or 4, we're starting to think about less restriction, even down to sort of over-the-counter access. Of course, not many people think that that's really the wise decision to go, and perhaps in the future we can talk about decriminalization. At this point in time, we're thinking about barriers to access post-market authorization in a medicalized paradigm. So we're assuming that psilocybin, when it reaches market authorization, is going to be rescheduled to Schedule 2. No lower than that. There's still going to be relatively tight controls. Again, there's not that much that we can do about this. We can't really intervene here. Then there's the costs. So there was a health economic analysis that was done by Professor Paul McCrone at the University of Greenwich. And he basically took the model that was used in the early imperial trials using psilocybin for treatment-resistant depression and said, well, how much does this cost generally? And could it be seen to be cost-effective for NICE to recommend it on the NHS? He sees that in that particular way of working, you've got 2 very highly skilled, very highly trained professionals in the room during the dosing. And so that obviously massively increased the costs. He wasn't able to look at group administration and use them as the model. What he's found using this sort of like differential analysis of the cost of a single dose of the drug being between £1,200 per single dose of psilocybin to £400 per single dose of psilocybin. He found that with that level of training and in that particular paradigm, it's very unlikely that NICE would recommend psilocybin for use on the NHS. We'll go a little bit more into that as we go on. But it's this area that we can have quite powerful interventions. Sort of how can we reduce these costs? What is the level of training that's necessary? Are there different questions around this about, whether you need to be more or less trained in certain venues, for example? And then you've got the attitudes of prescribers. So how will a prescribing psychiatrist know that they could, say, authorize somebody else to administer the drug on their behalf? Because if you don't have that kind of attitude, if you don't have that kind of ability for prescribers to trust other people to administer the drug, the prescribers always have to be present. Of course, the psychiatrist's time is more expensive than a clinical psychologist or a psychotherapist, or somebody that might not have those kind of qualifications but might be trained in, say, psychedelic guiding or facilitation. So these are the two areas where we can intervene, both on costs and on attitudes of prescribers. So I'm going to talk about two case studies, cannabis and ketamine, and what we can learn from them before we think about the implementation of psychedelics in a sort of perfect world scenario. So medical cannabis rescheduling in the UK, we're going to hear more about this later on with some of our other speakers, so I'll just gloss it. Essentially, we do have access to medical cannabis in the UK, but we have a two-tier system. There's a lot of nuances around this to do with the nature of the molecule and how it interacts with our individualized, totally unique endocannabinoid system that mean that it's difficult to... Yeah, sure, no problem. The endocannabinoid system is totally unique for all of us. And medical cannabis, of course, isn't one thing. You've got lots of different formulations with lots of different cannabinoids that work in interaction with the individualized disease entities too. So that means that it's very disincentivized for a drug company to take a medical cannabis product all the way through the phase 1, 2, 3 trials to market. Because they wouldn't be able to recoup their costs, these hundreds of millions that it takes to go through that process. So what we've ended up with is a situation where you've got a number of licensed medicines that are only available on the NHS for this very small number of conditions. We'll hear more about that later on, I'm sure. But then you have off-licensed medicines. So medicines that are being prescribed not for particular conditions, they're still GMP grade, but they have to be accessed privately, which of course means that people have to pay. This is obviously a huge barrier to access. Then you've got ketamine in the UK, where people have been trying to repurpose ketamine and also use ketamine medical products to treat depression. The problem is that every time somebody puts in an application for ketamine to be recommended on the NHS, NICE reject it. And they reject it for two reasons. One is the lack of long-term safety and efficacy data using ketamine for depression. They don't see that there's enough there. But also it's about the startup costs. It's about how you can have a cost-effective medicine where you have all this initial cost of setting up the infrastructure in the first place, repurposing, say, ECT clinics or purpose building new clinics for ketamine to be administered in. So we can learn things from these two substances about how we can implement psychedelics into the NHS. Here's a little timeline that just helps us think about what it is the problem that we're facing is. You've got the completion of the phase 3 trials. Shortly after that, the MHRA, one would assume, will grant a market authorization to one of these drugs. Then you've got this period of time where that long-term safety and efficacy data needs to be collected, where the drug needs to prove itself as being cost-effective so that NICE can recommend it on the NHS. We have an opportunity before the completion of the phase 3 trials to think about how to regulate that private space. If we don't get ahead of the game, we're going to end up with psilocybin or another psychedelic compound or a number of them reaching market authorization and it just being a no man's land, total free-for-all, no protections whatsoever. In that kind of situation where there's all this chaos, this sort of like pre-paradigmatic, regulation of the psychotherapies, etc. What we're going to see probably is a very quick movement towards regulation. This might mean a very, very tight clamping down and streamlining of these medicines in such a way that we might not be able to get ourselves back out of that situation. So if we regulate too tightly, too quickly, we've basically made work for ourselves later down the line. Some of this stuff is thought about and done with not just access to psychedelics as treatments, but perhaps also prophylactics and for other uses in mind as well later on. But we can jump that hurdle in a few years, perhaps. So what we're thinking about is how to facilitate NHS access through NICE recommendation. And what that means is we need to reduce costs of provision and facilitate data collection. And I'm going to take you very rapidly through how we have thought about this in consultation with a number of different groups, from lay practitioners, i.e. the underground and indigenous groups, to people working on clinical trials, psychotherapists, patient groups. Basically every single group that you can imagine has some kind of stake in this. So a perfect world implementation of psychedelic medicines. A model of access should, of course, minimize risk to patients. That's got to be the thing that's front and center, the most important point of all of this. But also, it's got to maximize benefits. So these two things we've got to keep in mind throughout, this balance. How do we maximize benefits and how do we minimize risks? Sometimes in order to maximize benefits, you've got to allow for a level of innovation. That's another point that I've been speaking about a moment ago about trying to avoid this over-regulation. You need to allow for a level of flexibility so you can have innovation so that then we can find out what might work best, or even allow for, as in the title, 1,000 flowers to bloom, multiple different ways of practice to be able to occur. So we have current mental health treatment pathways. This is the UK, but it seems to apply to many places. You have a treatment seeker, which we'll talk about a little bit more, and they can either go private or public, and get a psychiatric consultation and be put down any of these routes: take-home medication, alternative treatment, check into rehabilitation, etc. So we need to take this kind of model, this way of thinking about how people currently get access, and we need to integrate it with something like this. Perhaps not only this, because of course there are other ways of thinking about using psychedelics, but this is essentially, a sort of schematic diagram of how clinical trials work with psychedelics at the moment. You have your screening, preparation, dosing, and integration, all of which take place in one place. You've got a lot of therapists that are in relationship to the study group and the hospital, but aren't necessarily housed there. The treatment seeker goes all the way through and leaves the other side. This is a sort of nice self-contained package. Perhaps that's not the best or only way. So I'm going to fly through this bit because you probably all know something about this. We have a treatment seeker. Treatment seeker is an individual, essentially. This is a person with their own background, their own socioeconomic, religious, political situation. Thank you very much. And they need to be treated as such. They often arriving in a sort of state of inchoate pre-therapeutic distress. Something's wrong. They don't know what it is, but they need help. Perhaps they do have an idea of where their problems are, this kind of thing, but oftentimes people that are seeking help don't yet have a diagnosis. And, unlike the clinical trials, where we assume that these patients that end up going through them are sort of subject to discrete disease entities, there are often comorbidities and multiple different things going on for any patient, and that needs to be considered in the real world implementation of these medicines. So this person can go through a number of different courses of treatment. They can seek non-medical treatment, they can seek private psychotherapy. As we've said, they can go to hospital, or they can seek a medical consultation. And this is the most interesting and important point of all this, because this is where a consultation happens that potentially opens up a whole load of other treatments. So what I'm going to put forward is what we think a perfect world would look like. And of course, this implicates more than just psychedelic treatment. In our view, the best thing that can happen here once this person reaches medical consultation is that they're put in contact with a psychotherapeutic practitioner. From the beginning, from their treatment journey, they're always in relationship, no matter what comes next. Of course, at this point, they can have a variable length therapy before they return back to a psychiatric consultation. Then you've got all these other pathways that open up. Whether they're going to go to the pharmacy and get given a drug, whether it's a take-home medication or a psychedelic for administration, whether that's psilocybin, MDMA, DMT, SSRIs, antipsychotics, this person remains in that psychotherapeutic relationship. They're always in the psychotherapeutic relationship while they're getting the medication and going into the medical consultation, where the next decision is made in relationship between psychiatrist, patient, and mental health practitioner or psychotherapist. So when we're thinking about the prescription of a psychedelic medicine, we've got to think, well, this isn't a clinical trial. This isn't a one-size-fits-all thing. People have different needs, and perhaps some people need 6 months, 6 years of preparation before they get a psychedelic. Perhaps they only need 3 sessions. It should be on a patient-to-patient basis. And, after this administration, they return back to the psychotherapy. Perhaps they need more than 3 sessions of integration. Perhaps they need another 6 years. So what happens next? Well, that's a single dosing, but perhaps people need more than a single dose. Perhaps they need multiple doses. Perhaps they need to go around this circle numerous times, not only getting, say, psilocybin, perhaps they need to get psilocybin, 6 months later, MDMA, 6 years later, DMT. There's a lot of moving parts when we start to think about how all these medicines can be integrated together in a mental health system that already exists. So there are all these different directions that things can go. Not only that, there's a possibility of thinking about the different venues of administration. Perhaps it's more suitable for an individual with anorexia or PTSD to take this in a specialist clinic with other people that have the same condition. Perhaps it's more appropriate for somebody to do it alone with one practitioner. Perhaps there are patient populations that can't be accessed otherwise. Think of palliative care patients who might live in rural areas and can only have dosings at home. They can't get to a hospice or wherever they might be able to take it. So these are all elements that need to be considered. That's kind of like the overview. And what we've got to think about is what needs to be done to achieve something like this. What needs to be done that could allow for this proliferation of different styles of treatment, this individualized treatment. Essentially, to begin with, it's a change in attitude. There is a kind of hypertrophied risk aversion. Psychedelics are very safe, especially when they're administered in these safe, controlled environments. We're battling 50 years of stigma. We do have to highlight the risks. We have to be very clear and honest and sober about that. But at the same time, the risks can be minimized and perhaps avoided to some degree. We want the avoidance of biomedical capture so that we can have this proliferation of different treatments where they're thought of as enriching talk and other kind of psychotherapies rather than just a sort of medical intervention. But perhaps we want to allow for that kind of way of understanding it to continue as well. We need to remember that it's not one thing, avoidance of overregulation from the start, and attention to how these things have been done for millennia. Thank you. So what is practically needed? So the most important thing is that the prescriber knows who to trust to administer a drug on their behalf. We need to think about how we can get that to happen. Essentially, I've spoken to some psychiatrists and they've said they don't mind who's in the room during the dosing, as long as this person who's getting the dosing, the administration is happening in a hospital wing where that prescriber is present. I've spoken to other prescribers that have said, well, look, actually, I know a number of people that are qualified psychotherapists who have done other trainings, who I really, really know and trust have the skills necessary to be able to administer this drug in the context of their own psychotherapeutic practice, their own private practice room. And there are other people still that, are already practicing, administering in large groups, etc. The way that the current UK legislation stands means that it is possible for a prescriber to authorise somebody else to administer a drug on their behalf. But we don't have any of that regulation. So we need to start to think about how we can do that. I've written some of that here. I won't read it. Essentially, what it boils down to, what we think needs to happen, are these two interventions. We need a standardised registry of data where it can all be fed back into a singular place to inform best practice, to inform NICE about the regulation and the implementation on the NHS. And we need a college for psychedelic guides. Of course, that's just a random name that I've plucked out of the air. UK Association for Psychedelic Practitioners, whatever. Someone else will decide. But essentially, this could be made up of members of, say, the Royal College of Psychiatrists, members of the psychotherapy regulators, all together. And what they could do is think about the minimum training standards that are needed across the different professions, both psychiatrists, nurses, psychotherapists, etc., and how they could interact with the venues of administration. There could be, this says a little bit more about it. There could be the lines of accountability here, the supervision, etc. Handling complaints. We're actually already working on this. We've had a meeting in Parliament quite recently with the heads of the psychotherapy regulators. The Royal College of Psychiatrists were invited. Unfortunately, they didn't come, so we're writing to them to invite them to the next one, and it's a bit of an iterative process. We're actually hoping to set up a body like this where some of these things could be implemented, where we can regulate some of these trainings. So that's the big picture, my nice little diagram that helps me think, hopefully helps communicate it to some of you as well. Question is, why this model? Reduce cost of treatment. Psychiatrist doesn't necessarily have to always be in the room, but they can be. There's no requirement for an expensive hospital or clinical setting. That doesn't mean that you don't always have to have it there. It's about choice, it's about flexibility. Plurality of guides and containers, this is about best practice. Perhaps, somebody's going to do better with a guide or practitioner from a modality that they know, or a guide that shares the same religious outlook, or that kind of thing. Facilitation of real-world data collection, etc. And as I said before, it's already possible with the current legal and regulatory frameworks, which means that we don't have to go through the politicians. All we've got to do is do this through civil society. Of course, the political backing helps. So thank you very much for listening. I might have a moment or two for questions if you wanted. Thank you very much.